I'd like to introduce our first speaker tonight. Our first speaker is Tara Trewatha. She's a clinical psychologist. She works at the Outpatient Eating Disorders Service at RPA Hospital and in private practice at Brody Earl Clinical Psychology. Tara has worked with eating disorders across inpatient, outpatient and private practice settings. So thanks very much, Tara. I'll hand over to you.
All right, thank you for welcoming me. Sorry, I've just realized I'm not showing my video to you. Let me see if I can get that up. All right, I might just get started. So I will run you through a little bit about what I'll be talking to you all about this evening. So to start with, I'll briefly run you through the diagnostic criteria. We'll be talking a little bit about how to distinguish eating disorders from disordered eating. We'll be talking a bit about managing eating disorders in bigger bodies. And we'll also be talking about early diagnosis, so some things to look out for diagnosing eating disorders in the early stages. I'll briefly run you through a little bit about intervention for eating disorders, and we'll spend some time talking about language when we're working with people with eating disorders. So this was just something that popped up actually recently. It's an article by somebody in the medical field who has their own experience of an eating disorder. And I thought it was a timely reminder that there will likely be people in this webinar who have lived experience with eating disorders. I think it's also an interesting perspective to read through because it contains some helpful pointers for doctors from someone who's experienced an eating disorder and also has experience working with eating disorders in the medical field. So I'm not going to talk you through in detail everything about the DSM. I also won't go through in detail everything that's on all of these slides. I've put a lot of content on just so you can read through for your own reference. I imagine most of you are across the DSM criteria, but just as a bit of a refresher, so when we talk about anorexia, anorexia is usually the eating disorder that we usually think of first. So this is where we're talking about underweight individuals who either stay underweight due to fear of gaining weight or not recognizing the seriousness of their low weight. There's two different subtypes. So we've got the restricting subtype and the binge eating and purging subtype. We'll also be talking about bulimia. So bulimia, as you would probably know, is characterized by binge eating and compensating. So compensating, we're not just talking about vomiting and laxative use. We can also be talking about fasting or excessive exercise. So the main difference between binge purge anorexia and bulimia is that in anorexia, binge purge anorexia, the weight is low. So in bulimia, you'll see that their weight falls within the normal to overweight range. So if you're looking at distinguishing between binge purge anorexia and bulimia, if someone meets criteria for both, anorexia is always the diagnosis that trumps. So you would diagnose them with anorexia. The difference between bulimia and binge eating disorder is that in binge eating disorder, we don't see the compensatory behaviors. So you'll still see that people are binge eating. So you're looking for people who are eating definitely larger than what most individuals would eat, and that sense of a lack of control over their eating. OSFED is a category that we use where people have an eating disorder, but they don't quite meet the criteria of some of the other disorders. I won't run you through all of these, but I will draw your attention to atypical anorexia nervosa. So the reason that I'll point this out is atypical anorexia is where people meet the criteria for anorexia, but they don't have a low weight. So despite significant weight loss, their weight is still within or above the normal range. When I'm talking to consumers who meet criteria for atypical anorexia nervosa, I'll often leave out the word atypical when I'm talking about it. The reason that I do this is because consumers often interpret atypical as being less serious. But the thing is, with atypical anorexia, there can still be just as much risk of complications as with someone who is underweight, because you're still seeing that significant weight loss and you're still seeing those harmful restrictive behaviours. You can use your clinical judgment. If you do use the phrase atypical anorexia nervosa, I think it's just important that we really emphasise that it doesn't mean that it's less serious. It's just a different diagnostic category. I won't talk you through all of the OSFED criteria, but they're here for your reference if you want to look back at them. So disordered eating versus eating disorders. This is something that we talk about a lot. I think part of that is because fad diets and compulsive exercise regimes are really, really common. So the thing is, fad diets, they typically don't last. So that's something that we can sort of look at as a distinguishing criteria. But the problem is, if it is the early stages of an eating disorder, we do really want to catch it quickly. So we don't just want to be looking at the duration of the symptoms. We do want to look for all of the warning signs. So I'll talk you through in a few slides some of the warning signs to keep an eye out for. And I think you'll also get a little bit more information about this with the next speaker. Something that can be really helpful, and in fact this is recommended in pretty much all of the treatment guidelines, is to make sure that you seek information from family or loved ones where possible. So a lot of people with eating disorders won't necessarily give you the full picture of what's going on, and we often need information from others to get the real full picture of whether or not they meet criteria for a diagnosis. Obviously, it's not always possible, but wherever you can, get information from other people. Something else that's really helpful is to provide an assessment questionnaire. So I'll give you an example of one of those in a moment. But I guess the thing to remember is if the behaviours are unhelpful, so even if they don't meet criteria for an eating disorder, or if you're not sure, still educate people. So let them know the risks of restrictive eating behaviours if they've gone on some really intense diet. Even if they're likely to not stick to it, we still want to be making sure that we give people the information. If they come in reporting symptoms, so often you might have people coming in and saying, oh, I'm just really tired, or I've got this muscle soreness that won't go away, it's worth linking that to what's going on. So regardless of whether or not they meet criteria, you still want to do the same thing, educate them on the risks. Then the key thing to look out for is what happens once you've done that. So if you have educated someone on the risks and they don't change the behaviour, that's going to be a pretty clear warning sign. So if you've said, look, this restrictive diet that you're on is really unhelpful, I think it's likely contributing to the symptoms that you're reporting, and they then don't make a change, that's going to be a pretty big red flag that it's likely an eating disorder. At the end of the day, trust your intuition. So if something doesn't feel right, if you feel like the information you're getting in assessment is pretty patchy, if it's just not sitting well with you, refer for an assessment. So the NICE guidelines actually recommend that if you suspect an eating disorder, you should refer them on for an assessment. So you don't actually have to have made the diagnosis. If you suspect it, refer them on. Part of this is because eating disorders are often accompanied by limited insight, shame, defensiveness, and a belief that the behaviours are not harmful or even helpful. So a lot of people won't necessarily give you the full picture until they've had a really thorough assessment. And this shame, this defensiveness, I think it's important that we remember that it's not necessarily the consumer. This is a characteristic of the eating disorder. So it's not that they're just, an untrustworthy person. It's a characteristic of the disorder. The other thing is it's really uncommon for people to recognise that they have an eating disorder until the consequences have worsened. And even at that point, they often don't. So something that I often think about is working on the inpatient ward, often in groups, I will say to people, who here thinks that they don't have an eating disorder? And generally, most people will put their hand up. Most people who have eating disorders, even at the point that they're being hospitalised, don't actually think that they have an eating disorder. So refer for an assessment if you're not sure. Another important reason for that is that early intervention is a really significant predictor of treatment success. The longer we let an eating disorder run its course, the harder it is for treatment and the less likely it is that somebody's going to make a speedy recovery. I won't talk through all of the warning signs, but I've taken these from a really helpful resource, which I've referenced down the bottom. I encourage people to have a look at it because it's quite clear and concise and gives you some good warning signs to look out for. I've highlighted in bold some of the warning signs that you might see when people present in practice. So a common one that you might see is someone could be training through injury, or you might tell them they need to take a break from exercise and you see that they become really distressed that they can't exercise. That's going to be a pretty significant warning sign. There are a few here. One that I'll highlight is developing allergies to food. You may have already noticed this in your own practice, but a lot of people with eating disorders will come in looking into whether they're celiac or gluten or lactose intolerant, because often it's a safety behavior. They like to be able to use it as a reason to not eat foods like bread, pasta, dairy, because they could be fear foods of the eating disorder. And if you think about it, if someone's anxious about a food that they're eating, they're much more likely to be hypervigilant. So if I was afraid of eating bread, I might be really tuning into what's happening in my body. I might even have a slightly upset stomach because I'm feeling anxious. I might even have a bit of an energy crash after I've eaten it because the anxiety kind of drops off after I've gone through. And so people might actually experience symptoms, but it may be due to anxiety rather than intolerance. So I guess the thing to keep an eye out for is, do you have people who are really kind of pushing, no, I'm pretty sure I'm gluten intolerant, I'm definitely celiac, even though there's not really any evidence of that? That's a pretty big warning sign. If things like that come up and you suspect that there might be an eating disorder, it can be helpful to ask about a typical day of eating. And if it seems restrictive, so say, for example, they're not reporting much carbohydrate intake, they're eating small portions, or they're avoiding food groups, you might then want to follow it up with a more thorough questionnaire, or you might want to refer them for an assessment. These are some of the psychological warning signs. I'll draw your attention to distorted body image here. So someone saying that they're fat when they're clearly not, that's a pretty big warning sign. At that point, I would provide the EDEQ and I would most likely refer to a psychologist for further assessment. Poor concentration is something that a lot of people with eating disorders report, and that can be for a number of reasons. Part of it is because they're so preoccupied with thoughts around eating and weight. Another part of it could be because they have restricted their food intake. So if they're reporting poor concentration and there are some other warning signs, you might ask them again to describe a typical day of eating, and the same process, refer for an assessment or at least give them a more thorough questionnaire. Subtle cognitive changes, so thinking more rigidly around food and weight, or being defensive or protective of eating or exercise behaviours, that's a pretty good warning sign that there's likely an eating disorder going on. So same with all of these, you can't just use one individual item to determine that someone has an eating disorder. You obviously want to look at the big picture, but the more of these things that you're noticing, the more likely it is that there will be an eating disorder. The physical warning signs are some of the signs that you're probably more likely to come across in practice. The next speaker will be talking a bit more about what to look for when it comes to monitoring medical stability. So I won't talk about things like what to look for in bloods and OBS, but these are just some of the warning signs that you might notice when you're keeping an eye out for eating disorders. The gastrointestinal symptoms are quite common. So if someone comes in reporting those, I would always use it as an opportunity to ask about eating patterns, even if you don't really suspect an eating disorder at that point. If they do have an eating disorder, you might find that they're filling up on a lot of vegetables. That can obviously lead to a lot of gastrointestinal symptoms. You might also find that they're avoiding carbs or avoiding fats. All of those things are likely to lead to gastrointestinal symptoms. Same for binge eating, purging. So that's a good warning sign to look out for. And again, if you suspect it, provide a good questionnaire and consider referring them for an assessment. Abdominal pain, similar sort of thing that you're looking out for with the gastrointestinal symptoms. This can be a product of restricting or binging. I will draw your attention to weight change here. So weight change can be a warning sign. It is a good warning sign to look out for. If you're noticing or if someone is reporting weight change, it's a good idea to get a history of how much weight they've lost or gained over how long. Then you can start to see if the weight is yo-yoing a lot or if the weight change is quite significant. That can be an indicator of an eating disorder, and you might want to look at further assessment. But something to keep in mind is that most people with eating disorders actually aren't underweight. So we can't just be keeping an eye out for underweight individuals. Most people are actually going to be within the normal or overweight range. So I've got a couple of screening questionnaires. This one I quite like. The wording of it is quite nice. It's not particularly judgmental. This is the ESP. So these are 5 questions. It's recommended that you ask all of them. If somebody answers no to being satisfied with their eating patterns, that's an indication that you'd want to refer for further assessment. If somebody answers yes to any of the other 4 questions, that would also be an indication that you'd want to refer for further assessment. If you don't feel like you want to refer them for an assessment to another professional, you would at the very least give them an EDEQ, which is a longer questionnaire, and I'll talk to you about that in a minute. The SCOFF is another screening questionnaire. This one is recommended in a lot of the GP guidelines. It has relatively good sensitivity for picking up anorexia and bulimia. It's not particularly sensitive for picking up binge eating disorder. Something that I don't love about this particular screener is the 4th question here: do you believe yourself to be fat when others say you are too thin? You can imagine if you asked that question of someone who is in a bigger body, it can come across as a little bit insensitive. So if someone is in a bigger body, you might consider leaving that one out. That one's more of a screening questionnaire for anorexia. But with this questionnaire, people get 1 point for every yes, and a score of 2 or more indicates a potential diagnosis of anorexia or bulimia. It's not a diagnostic questionnaire though, so you wouldn't be able to just make a diagnosis based on any of the screeners. And in fact, that's what's recommended in the NICE guidelines. So they recommend that we don't just use screening tools as the sole method. If you've done a screener, you might want to follow up with the eating disorders examination questionnaire. So I've included a link to that here, which will score the questionnaire automatically for you. It will save you a lot of time, and it also provides the clinical cutoff information, which is quite helpful. So that'll give you an indication of whether or not it does look like someone may have an eating disorder. The EDEQ is useful for screening anorexia, bulimia, and binge eating disorder. You'll notice I haven't mentioned Arford yet, but I will get to that in a little bit. That's a slightly different eating disorder when it comes to assessment and treatment. But another thing that we see in the NICE guidelines is it doesn't recommend using single measures such as BMI or duration of illness to determine whether or not to offer treatment for an eating disorder. So as I've mentioned, the recommendation in the guidelines is that if you suspect an eating disorder, after an initial assessment, refer immediately to a community-based, age-appropriate eating disorder service for further assessment or treatment. Now, what the NICE guidelines don't talk about is the fact that the wait times are really quite long at the moment. We've noticed a huge increase since COVID. So something to keep in mind is really if you suspect it, you kind of want to get the referrals in process quite early on, because people can be waiting several months, and that's in community treatment, that's also in private practice as well. I won't talk much about treatment, but the main treatment that we use for the eating disorders mentioned so far is CBTE. So if someone is coming to a psychologist under an eating disorders plan, this is the treatment that we should be delivering. We use this for anorexia, bulimia, and binge eating disorder. So basically what it involves is there's 20 to 40 weekly sessions. The duration will depend a little bit on the presentation. We use food records, so we get a record of what they're eating. We also do weekly weight exposure. So weight exposure I will talk about a little bit, because this is something that consumers often really struggle with. So the idea behind weight exposure is that seeing the weight helps people learn that their weight won't exponentially increase forever. So that's what a lot of consumers are afraid of, that their weight is going to go up and it will keep on going up. We want them to see that that won't be the case. We also want them to learn that it's actually a lot harder to gain weight than they think. So weight exposure works in a similar way to exposure for phobias. So if you imagine having a spider phobia, apologies to anyone who potentially has one, but the treatment for that would actually involve exposure to spiders. So you would keep looking at them until your anxiety reduces to a manageable level. It's the same principle with weight exposure. So we want to teach consumers that they don't have to check their weight so frequently. We also want to teach them that weight fluctuations are normal. But once you're eating properly, your body will keep within a set range of weight. We also don't want to teach people that they should avoid their weight altogether. So avoidance of weight reinforces the idea that the number is too scary to cope with. Basically, people who avoid looking at their weight will still have this fear around weight. So we want them to learn that they can cope with the number and they don't need to be so hypervigilant and worried. So they can look at it each week, but they don't need to be frequently looking at it every day. And then we get to a point in treatment where we can actually stop weight exposure and they don't need to be looking at their weight and doing that exposure anymore. It is very common to get pushback on this, I will say. So you will often find consumers talk about how their therapist is making them look at their weight and they're very upset about this. You'll often get parents who are really upset that we're making their child look at the number on the scales. It can be helpful to, if you're concerned, to chat to the treatment team about it, but it's quite important to have, sort of team support around it. I'll talk a little bit later about measuring weight as doctors as well, because the approach, I guess, will be slightly different to what therapists do for weight exposure. So I mentioned Arford is slightly different. So the key difference with Arford is that it's not about body image, but you're still seeing significant weight loss or nutritional deficiency or difficulty getting nutrition through food, or avoiding food in a way that's impairing psychosocial functioning. So the key thing that you're looking for here is that there is no evidence of a disturbance in the way in which their body weight or shape is experienced. So people with Arford will typically be aware, like they should be aware if they're underweight. They don't have that dysmorphia that you would see in anorexia. And often they're actually quite stressed by it. They want to gain weight, but they have a lot of difficulty putting it on because food is so aversive to them. So we've got three main subtypes of Arford. There's sensory sensitivity. So that's where people avoid eating because of things like texture, smell. You might see that they don't like food touching on their plate. They might just have a general lack of interest in eating. So some people literally say to me, I just wish I could live off of Ensure. Like it would be so much easier for me. You might even see a fear of aversive consequences. So they're not afraid of weight as a consequence, but they might be afraid of becoming sick or choking or some other consequence happening because of eating. So Arford and anorexia often sort of get confused with one another. If you're screening for Arford, these are the types of things that you want to be asking around. So consumers with Arford will usually be more willing to gain weight, more willing to seek support around how to do this. So you can generally be a little bit more direct when you're screening for Arford and ask them about their food intake. and you can ask them about what's getting in the way of eating adequately. You might start to notice a bit of a flavour of some of these subtypes emerging with the way that they talk about it. If you're not sure, same with all of the other eating disorders, send them on to an eating disorder informed psychologist or psychiatrist, and they can do a more thorough assessment. But I guess another thing to keep an eye out for is individuals who only eat bland or beige foods. That's a common characteristic of people with Arford, or people who report a lot of fears around what will happen if they eat. Arford treatment, similar to the other eating disorders, we're still doing some exposure. We're doing gradual exposure. So we might initially start with just getting people to increase their intake of foods that feel safe. So they might be eating a lot of chicken nuggets and a lot of bread because that's what feels safe for them. But then gradually we get them to start incorporating foods that feel a little bit more scary. That's in essence what we do with Arford. It's really exposure based. The treatment guidelines recommend that we involve the family where appropriate because they can provide support at home. And the guidelines also recommend an MDT approach. So having a dietitian, a psychologist, sometimes we might even get an OT or a speech pathologist involved because they can help with difficulties with swallowing and things like that. Patients in bigger bodies with eating disorders. So I mentioned this before, but most commonly people with eating disorders are actually in the normal to higher weight range. There's also a significant co-occurrence of binge eating disorder and bulimia in higher BMIs. So something to keep in mind here is if you were considering recommending a weight loss intervention for someone, the treatment guidelines recommend that you first monitor for unhelpful dieting behaviours and treat important psychological factors. So if someone is using food as a coping mechanism, they're going to need to learn other coping strategies. What they've found in the research is that weight loss interventions aren't likely to be effective if eating disorder behaviours aren't addressed. So we need to make sure that we're addressing the eating disorder as well. And the recommendation here is for a multidisciplinary approach, which is the same for all eating disorders. We always want to have a team involved. Part of what's difficult here is we know that restriction can fuel binge eating, and binge eating can contribute to weight gain. So we need to make sure that if people are trying to lose weight, that they're not doing it in a way that they're restricting and just fueling more binge eating. Another thing that we need to be mindful of is that the research tells us most of us will have some level of weight bias, regardless of our body size. One of the things that can happen out of this is that they've found that consumers with a BMI in the overweight or obese range are more likely to delay or avoid healthcare because of actual or perceived disapproval of body weight, and partly because of higher rates of comorbid depression and anxiety. So what this tells us is we need to be really mindful of our language and how it might be interpreted by someone who's already anxious and expecting judgment when they come in to see us. We know that weight stigma often fuels eating disorder behaviour and fuels weight gain. This is a bit of a diagram which sort of explains how weight bias can keep eating disorders going and can maintain avoidance of healthcare. So if somebody already has a weight bias, they're quite likely to attempt to lose weight. So they might restrict, and they might find that that restriction leads to binging and weight gain. That weight gain in someone who's trying really hard to lose weight can lead to feelings of failure, shame, and a fear of judgment and criticism from others. Because of that, they're quite likely to avoid healthcare. So they're going to be quite scared of talking to anyone who's going to say, you just need to try harder, or you need to go on this diet, or you need to lose weight. Even if it's something that hasn't happened or isn't likely to happen, it kind of makes sense that if this is how someone's feeling, this is what they're going to be afraid of. So if they're avoiding healthcare, they're less likely to engage in any kind of treatment, whether that's for weight loss, whether that's for their eating disorder, or whether that's for something completely unrelated. But what might happen is if they've got an untreated eating disorder, there could be some kind of trigger. So say, for example, someone is purging or abusing laxatives, there could be medical complications that arise. They might have to go in and seek treatment, and they're going to be really fearful around that. If we don't acknowledge the eating disorder, if we don't assess for the eating disorder, basically what happens is it reinforces this weight bias. So someone might come in and they might be told, oh, okay, there's some health complications going on here, and it looks like it's probably because of your weight. So I think what we really need to do is focus on weight loss. If they haven't shared with you the fact that they're trying and they have an eating disorder, basically they're going to come away feeling quite misunderstood and feeling worse about themselves. And the cycle just continues. And this is something that we see quite frequently. A lot of this is because of the shame to do with eating disorders. Not many people will really go into their doctor and just outright say, hey, I've got an eating disorder, can you help me? The other thing is a lot of people with binge eating related disorders, they think it's just their fault. They think they're not trying hard enough. So they don't actually have insight into the fact that they have an eating disorder. So what we can do instead is just really make sure that we're screening for the eating disorders and empathizing with the challenges. So if we can explain to someone, oh, hey, what's going on here is actually an eating disorder. That's really hard. No wonder this has been going on. No wonder you feel so miserable. You can see how it would make the consumer feel more understood. They're going to be more willing to engage. And by engaging, they're likely to learn strategies to regulate their eating. It's going to give them a greater sense of efficacy. They're more likely to engage in treatment. And then we see improved health outcomes. So I guess the key takeaway here is just we always want to make sure that we're screening for the eating disorder before recommending weight loss interventions to people. And we really want to make sure we're being empathetic. And you'll notice that empathy is something that I'll talk about quite a bit in the next few slides. So because of the nature of eating disorders, consumers often don't believe that they have an eating disorder. So in restrictive eating disorders, you'll see people saying things like, oh, I just care about being healthy. People who compulsively exercise might say, no, it's not a problem. Exercise is just a part of my identity. People who binge eat might say, no, I just don't have self-control. I just need to work harder. The other thing is that a lot of people with eating disorders have difficulty making the links between their behavior and their symptoms. And that's something that we can help with. So if someone comes in reporting fatigue and muscle soreness, you can say, hey, that makes a lot of sense given the amount of exercise you've been doing or given these other behaviors. Helping them to see that there's a link between the eating disorder behavior and that they're actually experiencing negative consequences because of that. We know that consumers will often sort of filter that information out and focus more on information that reinforces the eating disorder behavior. So for example, if they see a diet or exercise program on Instagram and that fits quite nicely with what the eating disorder wants, they're probably going to be a little bit more likely to focus on that than someone saying, I think you should just cut out the exercise. So we want to be careful and make sure we're giving people the information. All of the research recommends the language we use needs to be non-judgmental, empathetic, and inclusive. Part of that is because of that cycle that we drew out before, we don't want to be doing something that's going to actually reinforce the eating disorder. We really need to make sure that people feel understood. You will find that often you'll say things and they might be misinterpreted. So often people who aren't getting enough food are going to be quite cognitively rigid, and they're going to be more likely to hold on to things that reinforce the eating disorder. So if you say to someone, it doesn't really seem like much of a problem, they're quite likely to hold on to that and disregard any of the information that says it is a problem. Other things that you might find will be misinterpreted are statements like, you look well, your weight is fine, you don't look like you have an eating disorder. This is something that consumers will often report as being quite upsetting to them, and they're most likely to interpret it as someone is telling them that they're fat. Obviously, nobody would mean that. Generally, these things are really well intentioned, but from an eating disorder mindset, they can be misinterpreted. So some of the more preferred comments are things like, you're putting in such a great effort if they're doing well, rather than commenting on their weight. If they're not doing so well, we want to focus on really externalizing the eating disorder. So talking about how the eating disorder is making things really hard at the moment, but we're still keeping the pressure on a little bit to make sure that they're continuing to engage in treatment. But you can see how with this language, we're doing it in quite an empathetic way. So the stance that we always want to take when we're dealing with eating disorders is one of firm empathy. We're being empathetic, we're acknowledging that it's hard, but we're still supporting them to make change. So you can see with this example here, if a consumer came in and said, I can't come in to see you each week, I've got so many appointments and I'm working full time, but you know they actually need to be coming in to see you each week. This is an example of how you could talk them through it, where you're acknowledging, yeah, that must be really hard, but you're still letting them know, look, there are too many risks. You do need to keep coming in to see me each week. But you sort of support them to problem solve a little bit, and you can collaborate. So if it's something that's workable in this situation, you might say to them, well, look, when you're further along in your recovery, maybe we'll chat about spreading things out a bit further. So the key thing here is you're not giving the eating disorder what it wants, but you're acknowledging and empathizing with what the consumer is saying. I won't talk you through this example here, but it's something that might be handy for you to have for your reference. You'll often have people come in wanting to sort of disagree with advice that their dietitian has given them. This is a way that you can kind of respond to that. And I've also included a resource that you can refer to just for your own reference for why dietitians make certain recommendations in the context of eating disorders. So taking weight, I mentioned this before. When people come in to see you, if you prefer, you can give the option of blind weighing where people don't look at the number. So the psychologist should be doing weight exposure. So they should be seeing the number with the psychologist. Because of that, it's okay if you want to offer blind weighing if they prefer. It's also helpful that you don't make comments like your weight is fine now, because what can happen is people will interpret that as, okay, this weight's okay, but anything above that is not okay. Another thing to be aware of is that weight will sometimes initially increase in treatment for bulimia and binge eating disorder. And it's helpful to explain to people that it's normal. Often they freak out a little bit at this. It's normal for your body to sort of hold on to weight until it learns that it's going to be fed regularly. A brief note on weight manipulation in restrictive eating disorders. So you might notice if someone has a restrictive eating disorder and you've said to them, look, your weight's a real concern, I think we need to consider an admission, and then suddenly you notice that their weight goes up a lot, you might want to be mindful that there's potential for weight manipulation. So things like wearing weights, drinking a lot of water, things like that to sort of influence the number. I've included a reference here at the bottom which talks about some things that you can do to sort of work your way around this. But what some people will do is they'll weigh people in a gown. And if there's really a risk, you might want to check their urine for risks of water loading. I wouldn't do that unless there was risk and you were really concerned about weight manipulation. But there are some precautions that you can take there. So something to keep in mind is what we're actually asking of people. Many people with anorexia don't believe that they're underweight. They don't believe that there's any problem with their diet or their health. So if you imagine being in that situation, like you personally, if you feel like your diet and exercise, you know, it's okay, and you imagine someone saying, well, actually, no, you've got an eating disorder. You need to eat more and you need to focus on treatment to get your weight up. You can imagine that it's not something that any of us would respond particularly well to, believing that, well, no, I don't have an eating disorder, I'm fine. This is kind of the same thing for someone who has an eating disorder and doesn't have insight. They're sort of going to freak out, and it's quite often that you're going to get a bit of pushback. Something else is that even in people who are aware that their eating is a problem, a lot of the time, the eating disorder is a coping strategy. So a lot of people with eating disorders have experienced significant trauma or other mental health problems. So what we're essentially doing by putting people through treatment is we're often asking them to give up their most effective or sole coping mechanism, and then asking them to repeatedly do something that's quite distressing by eating regularly every day and eating things that they don't feel comfortable with. So you can see how it could be really challenging for someone to give that up. The reason that I bring that up is because working with eating disorders, it can be really challenging. You might find that you get quite frustrated at times. It can be really frustrating having someone come in week after week and not making much change and seeing that their health is deteriorating rapidly. We really need to maintain empathy at that point, and that can be really hard. So I think really coming back to what we're asking can sort of help to hold on to that empathy and maintain a stance where we're not invalidating people. We're letting them know we get it, but you still need to keep working and engaging in treatment. I'll leave this little cheat sheet for you. But these are just some things, I guess, if you were to take away any sort of pointers, these are some helpful things to remember. The last little thing that I didn't talk about much is splitting. So we just need to be mindful that eating disorders thrive when members of the team disagree and provide inconsistent messages. So we really want to make sure that we're on the same team. That can be hard. Sometimes consumers sort of pull you to side with them or to disagree with things other treatment team members have said. Once splitting happens, consumers can lose faith in the whole team. So we really want to be mindful of that. I've got some resources for you all, which I will leave on the slides. Something that I will actually point out is that Inside Out has some eating disorder training, which is really good if it's something that you're interested in. And you can contact your local coordinator to get free access to that. But that's all for me. We may not have time to run through the questions. What are your thoughts, Kylie?
Yeah, thanks very much, Tara. That was a really insightful talk. I found it really helpful. I'm sure others did too. We might, how about we just try one or two questions? Okay, I've got one here. As a male GP, how worried should I be about treating an eating disorder in a teenage girl who is in an unhealthy overweight range based on a BMI? How can I tactfully address this scenario?
That is such a great question. And to be honest, this is something that I actually tried to look for some information for everyone on, because I think this is something that's really difficult. So I think the thing to be mindful of is you might want to focus on, like, if you think that she needs to lose weight, you might want to focus on what the symptoms are, focus on what the medical risks are. So you're not really focusing so much on the number, you're focusing more on the symptoms and getting her support around that. So you're not saying to her that there's something wrong with her for being in a bigger body, but if there are genuine health risks, you can point that out to her and say, look, I think maybe we get you some support. And as I mentioned earlier, you still want to do a bit of a screener. It is a difficult situation. Yeah, and I think even the fact that you're mindful of triggering her, I think that shows that you're probably going to have a pretty empathetic approach. So I wouldn't stress about it too much, still screen and focus more on the symptoms and the reasons that you want her engaged in treatment, not focusing so much on the weight and the number.
Great. I might just ask one more quickly, because you've probably got a good point of view on this. What can you do if a patient with disordered eating or an eating disorder has seen a psychologist and a dietitian a few times, but they don't want to continue treatment because they don't think it's working for them?
Yeah, look, it's so common. I would still encourage them to keep going. If they're not willing to go back to the person that they worked with previously, it's worth checking in with the previous treatment team to talk about what might have been getting in the way. and you might just look at sending them to another service. If they're quite unwell, you might consider a step up in care. So you might look at something like a day program, depending on where they're based. So in our Sydney local health district, we've got intensive outpatient program. There is a bit of a wait list, but yeah, if they're not progressing well in individual treatment with a psychologist and dietitian, potentially consider a step up in care.
Okay, great. Well, with that, we have hit our allotted time. So thank you very much, Tara, for your part of the talk. And we might move on now to our next speaker.
No worries.
So our next speaker, thanks, Tara. Our next speaker is John Hazelhurst, and he's an eating disorder coordinator with the South East Sydney Mental Health Services. John is an accredited mental health social worker and has been working in direct clinical practice since 2010. John went on to complete a Masters of Counselling Social Work in 2016, and shortly after this started his therapeutic journey at the statewide public health tertiary support unit. John has a keen passion for family therapy and building family and carer resilience. His passion extends to building workforce capacity, empowering individual clinicians and teams, quality improvement, and striving to achieve access and equity for people living with eating disorders, their carers, family, and significant others. So thanks very much, John, for joining us tonight, and I'll hand over to you.
Thanks, Kylie. I'll just start my presentation. So thanks for that introduction. So yeah, my name's John Christopheridis. I'm the Southeastern District Eating Disorders Coordinator. So before working in this current role, I was doing intensive family therapy at the tertiary support unit at the Peter Beaumont unit. And I've got quite an interest in family therapy and supporting carers. I also provide private practice at Camperdown as well. So for today, the objectives of the presentation today is to identify the early signs of eating disorders to aid in early diagnosis. We're also going to look at some of the signs that as GPs and allied health that you can monitor to assess medical stability. And then we're going to look at some referral pathways and eating disorder management plans and Medicare items. So in 2013, as part of the New South Wales Service Plan for people with eating disorders, it was expected that we integrated eating disorders into our everyday practices, and clinicians were seen to be creative and innovative in the way that they could integrate it. So part of that is providing training and support and building workforce capacity. So that way you as clinicians and practitioners can provide support to the people with eating disorders. So eating disorders people with eating disorders can suffer significant health complications, cardiac issues, bone density issues. They also have a much lower life expectancy rate. We know that because of the complexities that can come up, we need a whole MDT approach in order to be able to treat it properly and effectively. If we can manage to treat it early, then we know that this can assist with full recovery in the future.
Excuse me, John, sorry to interrupt. We can't see your presentation.
Oh, really? Oh, okay. One sec. Just say. Is that up?
Yes, and a full screen. Please present us view.
Oh, great.
Thank you very much.
Sorry about that.
Thank you.
So we know that people with eating disorders can be have a much lower life expectancy rate. One of the scary stats is that approximately 4% of the population live with an eating disorder, about 1 million people, and those living with anorexia nervosa, about 20% of those successfully complete suicide. So it's quite a significant number for a small population group. In terms of eating disorders, we do see that the presentation is not concrete. So people can move over a spectrum. So if someone is diagnosed with anorexia nervosa at one stage of their life, it doesn't mean that they're boxed into that for the remainder of their lives. People can move over a spectrum and say develop binge eating disorder. So what, in terms of patients, sometimes people might have severe restriction, but then as eating. And so what we start seeing is these maladaptive ways of coping with food. One of the, it does take about 7 years to achieve full recovery. So it's quite lengthy, and it does take a few good times to actually try and change. So it does take a lot of persistence and determination as practitioners. So there are a number of factors that can lead to developing eating disorders. So we know that there can be social, cultural factors that can influence people developing eating disorders. We see the likes of Instagram and Snapchat and the Insta famous culture coming through around expectations of being desirable and beautiful. We also see people that genetically, sometimes through a process of socialization or biological vulnerabilities, people can develop eating disorders. In terms of presentations, you might find that when you're having conversations with patients that they are so fixed on food and that it's hard to detract away from that discussion. Same with weight and BMI. We see people that can break up food into, they have very fixed food rituals where they might break up food into small bits. It might take them a number of hours to complete a meal. Often people might feel as though if they if they don't follow a particular ritual, that it could lead to a catastrophic event or the fear of weight gain or calorie intake or negative body image. People with eating disorders can strive for perfection. They can often overperform in a sense that their level of attention to mastering academically or work can really detract away from their lives, which can often lead to disorganization in their daily routines, can impact on their interpersonal relationships. And as Tara had mentioned before, sometimes people can suffer trauma. And so we do see sometimes, including adverse childhood events, people that may suffer things like neglect or molestation or sexual assault. So in terms of some of the high-risk groups, some of the similarities, say, with someone that may have diabetes mellitus or athletes are constantly taught or expected to have quite rigid food rules. So that can also become quite embedded in their own thinking. And so often when people are trying to steer away from that or trying to get away from that, they can be faced with shame and guilt. They also are expected to perform at a high level with food intake or with their medications or even athleticism. So there's that real focus on being able to perform and also having to meet other people's expectations. We do see that some of the high-risk groups can be women, particularly going through transition periods. So by transition periods, we mean women that maybe they're starting school or they're going through puberty and menstruation. They could be going through divorce or they could be getting married. So those are a couple of the high-risk groups. We are seeing that there's this culture of muscle dysmorphia where bigger is better. And so often, particularly in males, they might feel as though their bodies are not adequate enough to your usual muscular or masculine physique. And so what that can lead to is that they might overuse things like pre-workout or protein powders, which can have impacts on their kidneys. They can also abuse things like anabolic steroids, which can impact on mood and interpersonal relationships. So what we're seeing is that particularly men are starting to come through a lot with this. And one of the issues is that men can often go underdiagnosed as well. So in terms of some of the effects of starvation of the brain, you might find yourself trying to have conversations with people that might be malnourished or starved, and you might find that you're trying to help them to problem solve and get to a goal that they want to reach, but they might actually be stuck on a particular issue. You may find that you have circular conversations and that their thinking is quite fixed and concrete. In terms of the preoccupation with detail, cognitive remediation therapy, when it's being done, we can see that people might struggle with being able to look at a particular word that's written in a different colour, but they have trouble deciphering through what's actually the colour. You might find that in terms of exercise or pacing, people might be quite agitated and unable to sit still. There might be this very weird thinking as well, where they're unable to think about things in another way. People might be suffering from fatigue and low mood, or general feelings of sadness or irritability. When people present, they normally don't present saying, I've got an eating disorder. Normally they'll present because of other issues, for instance, diarrhea or abdominal cramps, gastro problems. Perhaps they're having anxiety if they're eating out in public. So this is why it's really crucial that if you're saying that there could be signs to an eating disorder, that we need to screen further. In terms of getting treatment, often there's a delay of 4 years between when people start having the symptoms and seeking treatment. And that could be because of a variety of reasons. One being stigma. Often people might feel as though they may be judged. So if they come forward, it might be dismissed, or people might say, oh, you're superficial or self-indulgent. So it's really important to be nurturing and supportive and empathetic when people are coming forward with eating disorder symptoms. So these are some of the hallmark symptoms that can present. So we may see that people have a really low body weight, and so people might be very underweight. What we see is when people are underweight, there's that muscle wasting and the bone coming through. People's jawline or cheeks might be more prominent in anorexia nervosa. For GPs, you might see that there's some abnormalities in the blood, like glucose, the neutrophils. We also see lanugo in patients with anorexia. So normally, lanugo is something that children have when they're born, and it's a way to keep the body warm. So people with anorexia nervosa can develop lanugo as the body's defense to try and keep it warm because it's so cold from being underweight and malnourished. So when we're screening or identifying for an eating disorder, if you suspect that somebody might have some symptoms, you can ask these 2 questions. These 2 questions help with having a bit of a gauge about and starting up some conversation to engage with your patient. So the first question is, I'm wondering if you have any concerns about your eating or your weight at all. And the second question, do you worry about your weight, or is eating an issue for you? If a person answers yes to either of those questions, then you can progress to the scoff, which is a pretty funny term given that people like to scoff food down, but it's one way to remember it. And you can also proceed to calculate the person's body mass index. It might also be worthwhile that if parents or carers are concerned about these things, that you should always screen further as well. So I know Tara had spoken a bit about the scoff just before. So the scoff has 5 questions, and so it's a good way to engage people and also just clarify a couple of things to help you determine whether or not to proceed with more of a comprehensive assessment. So I know that Tara covered this a little bit before, so I might just move to more of the comprehensive assessment for now. But in terms of children and adolescents, the early warning signs might be different for this particular cohort. So what we might see is that children might actually, or children and adolescents, might start to have more dislikes around particular food groups. Their interests start to change, and they might start to step away from things that they were usually quite happily engaged in. They might start to socially isolate and feel quite tired and lethargic. So if we know that when children and adolescents are at risk of an eating disorder, we know that they are at greater risk of medical complications, and that the impact on their development can be very significant. So it's really important that if you do have a suspicion that a child or adolescent is presenting with eating disorder symptoms, that you screen further. And you can ask parents those questions as well to get more of a detailed picture of what's happening for that child or adolescent. So these pictures show a pair of twins. So we can see that in infancy, but then the photo on the right is them when they're older. And we can see, well, we can guess who is the person that may have suffered from anorexia and endured a significant growth delay. So these pictures just show, I guess, the effects that anorexia nervosa can have on the development of kids. So in terms of assessing further, some of the things to consider are from a medical perspective, things like reviewing bloods or cardiac tests and your observations as well, your OBS. Having psychiatric input to review mental health history, risk of self-harm or deliberate self-harm, other comorbidities that might exist, such as drug and alcohol usage or other mental health issues. It'd also be useful to have some dietetic input, especially if you have concerns that there could be a risk of refeeding that may present if people start to have oral intake again. And also you can explore further around having a specific eating disorder assessment. So I know Tara had mentioned a bit about the EDEQ earlier, which is an examination questionnaire that is really useful, I think, in terms of gauging where a person's at in terms of their attitudes, their beliefs, their cognitions for eating disorders. There's also some other assessments that you can do as well, like the K10, that can help guide some of the diagnostic testing. So the inpatient management of adults with an eating disorder guidelines provide the clinical indicators for an inpatient admission. So that's a really useful document to have in terms of being able to look at the blood tests that are completed and your OBS, and being able to determine if somebody is within those clinical indicators. If someone is within those clinical indicators, then it may warrant a psychiatric or medical admission. So if patients are presenting in your offices and are presenting with these sorts of symptoms, it might be really important to seek emergency help. With these, people can have quite significant health risks if these are left untreated, and there could be severe consequences. So really important to seek emergency help if these are presenting. So these are some of the clinical indicators that these are the clinical indicators that are in the inpatient guidelines. If patients are presenting within these clinical indicators, this is what warrants a medical admission into a local hospital. So the clinical indicators cover things like electrolytes, cardiac issues, and also renal functioning, just to name a few. So if someone has been restricting their dietary intake for a period of time, it can be really dangerous to reintroduce food. So it's really important that when reintroducing food, that carry this risk of this syndrome. So there could be a potential fatal shift of fluid and electrolytes that can occur, and people can actually suffer sudden death as a result. So it's really important that if you have specialization in this, that you're able to identify that and be able to manage it properly, or seek dietetic support, or send them to hospital. So in terms of referral pathways, these are some of the referral pathways that currently exist. If, for instance, somebody is within the clinical indicators for that warrant a medical admission, which is the red box above, then people may need to attend an emergency department, or alternatively, you can organise with the AMO a planned inpatient admission or psychiatric admission. Sometimes practitioners and allied health members can face barriers to accessing hospital admissions. If that is the case, part of my role is to facilitate and provide facilitation for those sorts of referral pathways, and I can advocate for that patient, particularly if it's within the clinical indicators. If you've seen someone and you can see that they might be showing early signs of an eating disorder, we would encourage you to continue monitoring them, whilst also considering whether or not psychology or dietetic intervention might be useful. It'd be really important to gauge that with them and see where they were at and if they were happy to seek additional allied health input. If people have a diagnosed eating disorder and their symptoms might be quite chronic and they start to become disengaged, it would be really important to continue your treatment as GPs and to continue monitoring, but also consider community case management from your local community mental health services. That can assist with engagement and monitoring that person to making sure that they're safe and okay. If you have any barriers with seeking community case management, part of my role is providing pathway facilitation as well. So I can also assist with those processes. So the continuum of care provides us with a step up and step down paradigm. Patients can move up and down the pyramid. It's not linear, so people can move from one section to another. In terms of the generalist health and mental health interventions, the main focus here is really targeting some of the symptoms, continuing with monitoring, providing some psychoeducation around eating disorders, and perhaps linking them up with some self-help or e-therapy options that are available online. Some of those might include like Smiling Mind, there's also Calm, so that can help with managing feelings of distress. If people within the clinical indicators for a medical admission, it might move to a local hospital intervention where people need to have medical stability and also some nutritional rehabilitation. So that might look like NG feeding or meal planning by a dietitian. But also the local hospital intervention gives them some time to have some symptom containment as well to promote safety. If people become more unwell, the tertiary hospital supports are normally for the most chronically unwell. So they can provide medical stability as well as nutritional rehabilitation and psychological therapies. So these do have long wait lists, although it is a type of treatment that can be sought if people are really struggling and have tried other alternatives as well. Unfortunately, within Southeastern District, we don't currently have any specialist eating disorder interventions just yet. What these interventions normally look like is similar to where Tara works. So basically their role is to provide the sort of CBTE and specialised outpatient programs at the Peter Beaumont unit. And the main roles here are really around normalising some of the eating disorder patterns and behaviours, providing some level of safety around the symptoms and the loudness of the eating disorder and the difficulties that arise, but also working out and trying to develop better ways of coping to focus on building their self-agency and independence. So on the 1st of November 2019, a suite of 64 Medicare benefit schedule items were introduced to support a model of best practice evidence-based care for people living with anorexia nervosa, bulimia nervosa, binge eating disorder, and Arford. So the listing of these items was a result of the recommendations in 2018 by an independent clinician-led medical benefit schedule review task force and the Australian government's response to those recommendations. The new structure means eligible patients can receive a Medicare rebate when eligible providers, such as a GP, psychiatrist, or paediatrician, undertake the development of an eating disorder treatment and management plan. Following this, they can do a review at 10 sessions. That can also be Medicare rebated. The eating disorder treatment and management plan can activate a course of evidence-based eating disorder psychological treatment services up to a total of 40 psychological services in a 12-month period, and also up to 20 dietetic services in a 12-month period, depending on their treatment needs. It is intended that the MBS services will be provided by practitioners with the knowledge, skills, and experience in providing treatment to patients with eating disorders. Treatment can be provided under the eating disorder psychological treatment items that are limited to the defined list of evidence-based eating disorder specific treatments. Patients who don't fit the eligibility criteria for the MBS eating disorders treatment pathway might be eligible for treatment under the Better Access to Mental Health treatment pathway as an alternative. After 12 months, there will be an evaluation of these items around their operation and for the providers and how it's being used. So this is the criteria for people to be able to receive, or for people to be able to be eligible for an eating disorders management plan. So the person does have to have a clinical diagnosis of anorexia nervosa, bulimia nervosa, binge eating disorder, or Arford. The person has been assessed as having completed the EDEQ with a score of 3 or more. There may be some the person's condition around rapid weight loss, or if they're having uncontrolled binge eating, or inappropriate compensatory behaviours such as laxative abuse, exercise, or purging. So I won't go through the full list, but criteria is fairly extensive. And if people meet that eligibility criteria, then they're able to access an eating disorders management plan. So the Medicare items can be provided by general practitioners, including the preparation and also review forms as well. The Medicare items are timeframed, so it's important to go through each one because each Medicare item has a specific time frame, and within each Medicare item there is a different fee and benefit structure that depends on the time and also the competencies of the general practitioner providing that service. So for instance, if a GP has specialisation in eating disorders, or more broadly, if they have specialisation in treating mental health issues as well as their GP practice. So the eating disorder psychological services provide mental health treatment that can be provided by an allied health professional, such as a clinical psychologist, mental health accredited social worker, mental health accredited occupational therapist, or a medical practitioner in general practice, as long as they've got specialised mental health training. So these are some of the items that do exist. There's quite a number of them. So I'd encourage you to go online and have a look when you have a chance. In terms of reference guides, there is a quick reference guide available online, which I've listed in the resources at the end of this presentation. And the Inside Out Institute has also developed an eating disorders plan template that can be found on the National Eating Disorders Collaboration website as well. So involuntary treatment is normally used for people under the Mental Health Act or Guardianship Act, where people may not be able to make appropriate decisions for themselves or could be putting themselves in danger. To utilise the Mental Health Act, patients need to meet 3 criteria. So the first criteria is around mental state. And so that's if somebody is having very concrete and fixed ideas around food or body weight, so much so that they can't segue into other conversations. Their behaviour might be quite irrational and putting themselves in danger. And they could also have real trouble with being able to sit still or just experiencing high levels of distress around the eating disorder cognitions that are coming through. So the second criteria is around if somebody might be feeling suicidal or at risk of harm. And the third criteria is if that treatment is really the most safest and effective care for that person at the time. So we do see a lot of challenges when we're doing this work. And I think more often than not, people can struggle with how the recovery rate can be very slow and it can take time. So using a strengths-based model, we might think that recovery can take a long time, but it is possible. And holding that hope for patients will help them know that they can achieve recovery. Another tricky part as well is when we're considering some of the stages of change, people may be feeling very stuck and unable to make that change, make that decision to get better. So we call this, which the ambivalence can lead to resistance. So when we're trying to treat patients like this, we use a term called rolling with resistance. And so by rolling with resistance, one of the components can be around providing that validation and support around how difficult it is, but also recognizing the need for change and trying to hold the goals for them. People with eating disorders can often, they will often think that it's everyone else's problem, as opposed to actually being able to recognize that the problem is coming from either the eating disorder or their own behaviors. So that can be a real challenge to deal with as well. And also remember that when patients might be presenting with communication challenges, or might be doing things such as hiding food or purging behaviors and trying to keep it secret, that keeping the secret is actually designed to protect the illness. It's a way to keep the illness away from being seen, so that way it's not seen. So some of the core components of providing patient-centered care are and remain engaged with that person. We know that affect regulation and providing that nurturing role can enable someone to open up. So it's really important to remain engaged and supportive. Michael White's work around externalizing the condition can also be very helpful. It sees that we see the person as separate to the actual eating disorder. So sometimes this can help patients by visualizing the eating disorder as separate to themselves and see how it's actually affecting them or impacting on them and their lives. Sometimes externalizing doesn't work though, and perhaps the person might have lived with the condition for a period of time or not be ready to separate the illness from their own identity. If that's the case, I wouldn't use externalizing then. I would continue with providing a collaborative approach and also compassionate care. Part of what can guide your practice as well is meeting the person with the stage of change that they're at. So that might, in terms of change, sometimes when patients might present, they may not be ready to change. They might be in that pre-contemplative phase where they're thinking, oh, I'm not sure, I really want to hang on to this, it serves a function. At other times though, patients might start to make certain changes around their meals, around their eating patterns, or their binge purge cycles. And so using that action point can be really crucial to keeping up the momentum. We also really need to just be very careful around our communication, not just in our own interactions with the patient, but within teams. Cognitive impairment can create lots of issues with communication, and the eating disorder really feeds off splitting as well. So it's really important to stick to the treatment plan and also stick to the treatment plan of the MDT. So some of the pathways to care that currently exist within Southeastern Districts is the community mental health services, which have a responsibility to provide care and support for this population. In terms of inpatient, in Southeastern District, we don't actually have a specific eating disorders unit. And inpatient treatment is normally depending on the hospital. So the tertiary services are listed there, so you can write their numbers down. The tertiary services, so the Peter Beaumont unit is a 9-bed unit, gazetted unit that can provide intensive support for people living with eating disorders. There's also the child and adolescent unit at Westmead and Randwick Children's Hospital listed there too. The tertiary outreach services offer consultation liaison to multidisciplinary teams, particularly around people living with complex problems regarding eating disorders. And then there's also local pathways to care from some of the metro hospitals in Sydney and New South Wales. So sometimes there can be a little bit of a wait for them, and usually patients do need to be medically stable to access them, but they are normally done on a voluntary basis. And also patients do need to have access to private healthcare, which can sometimes be not accessible for patients who have financial constraints. So I've spoken a little bit about communication already. I think it's really important to reach out and seek support amongst your colleagues and your networks. It's really important to be aware of some of the values that of ourselves around food and our relationships around nutrition and oral intake. So that way we're aware of how that may come across to other patients as well. Sometimes when we're doing this line of work, we can feel frustrated, or we can feel like, why isn't this changing? Is this actually, is this because the type of work that I'm doing isn't meaningful? If that is coming up, that can be normal, and I encourage you to seek support from your colleagues or a supervisor to talk that out and get the support that you need. So I'm the local eating disorders coordinator at South Eastern District, and my contact number's there. There's also a range of other coordinators that can be found on the site. And also the Inside Out Institute, which offers fantastic e-learning programs. So one of them is the Essentials training, which has about 17 hours of interactive videos, great resources, templates, really good written resources that can be accessed. And if you needed access for that, you can send me an email if that is something that you want to access. The other trainings available are around meal support, inpatient management, community management, just to name a few. So I'll jump onto the Inside Out Institute website and have a look and see what resources and trainings are available. So these are some of the resources that are available for GPs and allied health. You can have a look through these when you get a chance. Also, the Eating Disorder Examination Questionnaire is available on the Inside Out Institute website. And if you're interested in some of the Medicare items, or if you want quick access, quick reference guides, you can find those available on the Services Australia website.
Most of you here will know Dr. Martina Gleeson. She's the clinical lead for general practice for the South Eastern Sydney Health Pathways, and I think she's going to give us a quick 5-minute update for Health Pathways.
John, can you please stop sharing your screen?
Oh, yes.
Hello, everybody, and thank you for hanging in there with me. I promise to make this very quick for you. I really wanted to let you know the resources that are available for health pathways for the management of eating disorders. And because we have possibly people attending from the Sydney Health District as well as South Eastern Sydney, I'm going to introduce both lots of health pathways. So that would be good if it would actually go ahead. There we go. So if you hold your camera up and screen the QR code, which we're all becoming experts at now, that will take you to the classic site for South Eastern Sydney Healthways. The username is SE Sydney and the password is healthcare. If you want to use the mobile-friendly site, which is better for using on mobile phones, same username, same password, and this QR code will take you to that version of the website. Just a quick rundown of the eating disorders pathways that we have so far on South Eastern Sydney. We have got a really good summary of the eating disorder treatment and management plan with a link to the online calculator of the EDEQ score. We also have adult eating disorder specialised assessment and child and adolescent eating disorder specialised assessment, which will help you find those resources that some of you are asking for in the Q&A. There's also eating disorder support, eating disorder advice, and John lives on that page so that we've got the contact numbers for him. There's also some components for eating disorders on both the adult e-therapy and the child e-therapy guidelines. So pathways, So that answers another question in the Q&A. And there's also mental health helplines. We also have in development clinical pathways on anorexia nervosa, bulimia nervosa, and eating disorders in children and youth. They're nearly ready. We're just trying to get some input on the long-term management of people once they're in recovery from eating disorders. There's also Sydney Health Pathways. Their services are based in the Sydney Local Health District, and you can use this QR code to log on to them. Their username is connected and their password is healthcare, but because our teams are in the same PHN, you can actually use the login for either of the health pathways to access the other one. So we're just trying to make it a little bit easier for you. That's the QR code to the mobile friendly site. Just give you a minute to quickly flash your camera if you want to access it. Their pathways, they have clinical pathways on a general one on eating disorders, one on anorexia nervosa, bulimia nervosa, OSFED, and the eating disorders treatment and management plan. And their request pathways are eating disorders treatment for children and adolescents, eating disorders treatment for adults, and online mental health therapy for adults. And finally, I really did make it brief for you because I know we're running out of time. Our Health Pathways team is very interested in hearing from you if you're a GP with a special interest, and because we're developing a health pathway where we can help identify GPs who are happy to take referrals from other GPs for a specific thing, like maybe inserting a marina or iron infusions. We have quite a long list of special interests that we're trying to help identify GPs who are happy to look after patients for those episodes of care without taking over the care of the patient. So if you're interested in having your practice listed on some of those special interests, then there's Sue Baker's email address, and there's also my email address. And if you email me, I'd be happy to send your details along and we'll get you up